I'll start with Parkinson's. Really what I want to, I think I skipped over actually prevalence and incidence. So getting to symptoms, the main features, so there's positive, there's negative, there's cognitive symptoms, and then the underlying mechanisms, so what's happening to the brain, and then some treatments that are, have been proposed for Parkinson's disease, some that are in use and then some experimental, going back again to some of the stem cell research. Alzheimer's disease, I'm going to focus a bit on dementia because I think this is it's good to make the distinction between Alzheimer's disease as a brain pathology versus dementia, which is a set of psychological factors that you can actually see. So this is often confusing because if somebody says, oh, I have memory loss, oh, I can't remember what I had for breakfast 2 days ago, they think they have Alzheimer's disease, when in fact it's not the case, and in fact most of us forget what we had for breakfast 2 days ago anyways because it's not that important. But there are these signs of dementia that can be related to any brain pathology. So Parkinson's disease has dementia components. There's a lot of different brain pathologies that cause dementia. Alzheimer's is a brain disorder, so there we go, it's not a disease in my case. It's a disorder of the brain that leads to dementia. And what are the clinical features, and then the neuropathology, and I have some cheap visual aids to hopefully help sort of illustrate what the pathology is in the brain. So this is where I want to start with dementia. So what are the neurodegenerative disorders with a component of dementia? So it's an intellectual impairment. So dementia is something you can ask somebody about and they can tell you, or they can display signs or symptoms that they have dementia. So it's an intellectual impairment, it's memory loss, it's, so there go memory, cognitive deficits, and then it also gets to be, so again, we all, from about 40, we all start having memory issues, and that's not uncommon. Our brains can only store so much, so some things have to go, some things have to be put in. You can remember some things, if you think about when you were 5, let's say, there's all of a sudden these weird memories that pop into your head. So memories are a bit funny, and I could probably give an entire 6-week course on just memory itself because I think it's a fascinating topic. But so this is one of these things that, it comes and goes, and, we think that if you forget something, then it's gone, but then all of a sudden it'll pop up, and it's a very strange phenomenon. But in dementia, memory starts to really get impaired so that you start forgetting that you had breakfast, you start forgetting, to eat, that you forget who your children are, what you forget faces, you forget some things that really you should not be forgetting. Forgetting the name of some actor or actress is pretty common, but there are certain types of memory that start to decline in dementia that really are a cause for alarm, as well as your social and occupational functioning. So you can't, come to a class like this when you really want to. You can't go to work anymore. And work, again, in most of these cases, the occupational problems associated with dementia are those in the younger crowd, obviously, who have to go to work. And that's a cause for alarm too. So thinking about concussion, people who have multiple concussions do develop dementia when they're, let's say, 40 or 50, and then they can't go to work. So that's a real impairment in their ability just to perform day to day. So there's two types of, degenerative dementias. There's the non-degenerative and the degenerative. So we're going to be talking about the degenerative today, so Parkinson's and Alzheimer's. There's, as it says, have a degree of genetic transmission, but there's also a particular cause, or there's some known aspect about the brain that's sort of starting to, go along a particular pathological time course. Whereas the non-degenerative disorders, that's a complicated way to say that there's a lot of different causes for these. So let me just put up an example, this table. So on this side you have the degenerative disorders, on this side you have the non-degenerative, dementias. So again, the dementia is, and I'll talk more about this when we get to the Alzheimer's, but the dementia is something that you can see in a person, so that their memory is going, their social function is going, their occupational involvement is going, and that can be caused by Alzheimer's-like pathology, so that's what I'll be talking about today, or Parkinson's-like pathology, but also Huntington's disease has dementia components, frontotemporal, cortical basal degeneration, prion diseases, so Creutzfeldt-Jakob disease or mad cow disease. All these are pathologies that people can, sort of say this is what's causing the problem in the brain, and then it's associated with this observable change in behavior, which would be, in these cases, dementia. On the and then as well as these are progressing, the brain starts to degenerate. Whereas these non-degenerative, you can see that there's infectious dementia. So with AIDS, you have a virus that can cause a person to, have certain psychological deficits. Post-traumatic dementia, so the post-traumatic stress disorder, anxiety. I would even put concussion up here as a non-degenerative cause of dementia. Chronic alcohol or drug abuse would be classified as a non-degenerative dementia. So these are, I guess, you could say, acquired diseases that cause dementia. These are also acquired, but there seems to be some particular genetic component, some particular pathological process that we can track and actually, try to understand how we can cure it. So Parkinson's is one of those. It's a degenerative disease or disorder, and it's associated with cell loss in a particular part of the brain that produces dopamine that helps you move. So, I mean, obviously the main clinical features, just like I said, didn't have that, but the main clinical features of Parkinson's disease is a movement disorder. So there's the tremor at rest, and then there's an inability to initiate movements. And this part of the brain, the substantia nigra, it's just a small little cluster of cells down in the base of the brain. Probably, well, not quite the base, it's classified as the midbrain, but it's just a little dot down here. And I'll have a illustration of that as we go along. But it produces this chemical dopamine, which is important for, it's important for a lot of things in the brain. Mostly it's important for movement, as well as when people's dopamine goes up after they take a drug, people get addicted to that drug. So the dopamine response to a particular drug often predicts how addictive that drug can be. And when you have damage to the dopamine system and this particular little cluster of cells, the substantia nigra, that often leads to Parkinson's disease. So we'll go through that as we move along. So this is, again, one of these things that we have to always be careful about how we talk about, let's say, something like Alzheimer's or Parkinson's disease, because these types of disorders will increase as we age. But a lot of the symptoms associated both with Alzheimer's and Parkinson's are similar to changes that take place as a consequence of aging. So you can imagine that sometimes it's harder to get up. Sometimes, you do just have some mild shaking, but it's not necessarily Parkinson's disease. That's just a normal aging process. So we always have to be careful, and this is especially, I always talk to my mom about the Alzheimer's situation because she says, oh, I forgot, I had an appointment today. Does that mean I have Alzheimer's disease? And I'm always quick to say, no, that does not mean you have Alzheimer's disease. That just means you're a normal aging person. So we all forget things. And we all have, motor, we all can develop these motor, deficits or just motor sort of slowness, I guess you'd want to call it. So where is the main problem in Parkinson's disease? So as I said, I showed this little cross section. So again, if you're looking forward, you split the brain in half. That's what's shown up here. So it's just these little dots down here, and they have long projections that come into different parts of the forebrain. So this one on the top here that projects up to a region called the basal ganglia, that's what it's these cell bodies that start to die off in Parkinson's. And you only actually see the symptoms when about 75% of those cells die. You reduce the amount of dopamine that goes out to here, and once that dopamine signal is gone from here, movement starts to be dysfunctional, as well as thought processes. So the dementia aspect is also related to the decrease in dopamine out to that area. So it's this part of the brain, this basal ganglia, again, that's a really, I think, a fascinating structure. It's really important for movement, so it's important for inhibiting involuntary movement. So when in Parkinson's, that tremor, it's because there's no dopamine there, as well as it's an important part of the brain for initiating movement, so getting up and taking a walk. It's also an important part that seems to be, there's these loops with this, again, this frontal cortex, the part of our brain that makes us who we are, that's really important for, just thinking, essentially. So this part of the brain organizes thoughts that come through the frontal cortex. It helps to just sort of straighten out things. Obsessive-compulsive disorders, often thought of a disorder that's based in the basal ganglia. Huntington's disease is actually cells that die here in the basal ganglia, so then you can't inhibit those involuntary movements. So you get the chorea, the dancing of Huntington's. ADHD, there's a lot of things that people think that this part of the brain is really important for. It's a lower, subcortical structure, but it really interacts with all these higher level brain structures, so the frontal cortex, the motor pathways, to organize thoughts, to organize movements. And when you get any imbalance there, if you get decreased dopamine or increased dopamine or loss of cells there, you can really see the effects pretty severely. So anyways, back to this part, at least in Parkinson's, it's those cell bodies that get destroyed. And again, we start to see some correlates that we've been talking about in the past about different types of degeneration. So in MS, so you get reactive oxygen species. There's this high rate of metabolism that's going on. So if you don't have a lot of antioxidants in your system, then these cells are really sensitive to these reactive oxygen species, so low levels of antioxidants, and they start to get damaged. And again, related kind of to what I skipped over in MS, but there's a high iron content in this part of the brain, which also seems to make it susceptible to destruction. Not in everybody. So this is I guess more of a schematic of where these projections are, what's happening, I guess, in Alzheimer's. So if you look down here, this is that brainstem area, that midbrain area, that's the substantia nigra, that's important where the dopamine cell bodies are. So you can see that this would be classified as a normal brain on this side, and this would be a Parkinson's sort of brain. So you can see what's happening is, maybe not that clearly in this picture, but we'll get better pictures of that. The connections up to this basal ganglia center, these darker lines, those are all dopamine projections. Those lines have actually decreased because these cells are dying off. So in that case, there's less dopamine being able to be put into this basal ganglia. As well, there's less of an information exchange with that frontal cortex. So you not only get the movement disorder that's based on destruction of this part of the brain, but you also get some associated dementia, so the loss of intellectual function, let's say, that's associated with this frontal cortex. So you can see the normal brain, nice dark projections, really heavy projections up to that frontal area that allows us to, socially function and have our intellectual capacity that we have. But as that dopamine gets depleted through this system, you get movement disorders here, and then the dementia, the intellectual disorders. So there are just these four primary symptoms. As I said, Parkinson's is mainly based on movement disorder. It's typically diagnosed when you have the movement disorders, although again, it's really an unfortunate case, and I didn't put this up here, but it's not until about 75% of those neurons in that substantia nigra die, that's when you see the movement disorders. So people are starting to look, before that happens, to say what kind of markers can we see, at least, behavioral changes can we see that might predict somebody's going to develop Parkinson's disease. And one thing that people are starting to look at, this is in Parkinson's and Alzheimer's disease, is a loss of smell. So not body odor, but the ability to detect other people's body odor, let's say. So the olfactory abilities often start to decrease rather early on in both Alzheimer's and Parkinson's. So some people are looking at that as maybe a marker for preclinical, just some way to diagnose either of these disorders. But typically, back to Parkinson's, it is this, so the main two features are the shaking. So typically when I talk about this for my students, I show a video of Muhammad Ali, who doesn't probably, it's hard to say what he has. He has Parkinson-like disease or disorder. Possibly not Parkinson's, but he got pounded on the head quite regularly throughout his life, and now at an old age, he definitely has Parkinson's. So when he sits, he just sits and shakes, so that's that tremor at rest, hands, arms, leg, face, and then he also can't typically generate a movement. So he has that, what's called bradykinesia, slowness of movement. So just being able to sort of, make that movement to get up and start walking. And oftentimes in Parkinson's, once people do start walking, they kind of, go on their tiptoes and they can't stop. So it's really challenging because you do have this impaired balance coordination, so people fall, so you have to have, walkers or canes or something else to help you stay upright. So again, typically in a lot of disorders of the brain, the symptomologies are classified as positive symptoms, negative symptoms, and then often there's also cognitive symptoms. So in schizophrenia, that's the case. In Parkinson's, it's the case. So in Parkinson's, positive symptoms are something that emerges. So that all of a sudden, from before the disease hit, there was nothing, and now after the disease hits, there is something. So in this case, it's that tremor. So before you have Parkinson's, you don't have tremor. Once you develop Parkinson's, it's a symptom that's all of a sudden positively shown. In schizophrenia, it's classified as the hallucinations, the delusions, things like that. So things that before the disease hit were not there, things that now that the disease is ongoing, those symptomologies appear. So these involuntary movements, changes in posture, motor restlessness, involuntary turns of the head, the eyes to one side. So it's very difficult. And if you've ever seen any videos of Michael J. Fox, he's another good example, who has quite a bit of the positive symptoms of tremor at rest. They showed him trying to put toothpaste on a toothbrush, and it's just it's impossible. And he jokes about it all the time. He says shaving is an experience every day because he's always afraid he's going to really cut himself badly. So those are the positive symptoms. The negative symptoms. So again, negative symptoms are often a decrease in ability. So again, that's the decrease in the ability to get up and walk. And once you get into that behavior, you start walking faster and faster speeds. This should probably say about there's the issue of just initiating a movement. So functions now are going down. So negative movement or negative direction of symptoms. So they get worse as you develop the disease. So in something like schizophrenia, it's depression, it's apathy, it's just the inability to just initiate any sort of interactions with people. So you have these two types of the positive symptoms, which is the tremor, and the negative symptoms, which is the decrease really in locomotion or the inability to get moving, slowness of movement. That's probably the best way to talk about it, the inability to initiate movements.
Prosody? What's prosody?
So when I'm talking, it should sound more like a song. I just keep going and going. Whereas in Parkinson's, it's a bit, I don't know, I could do it. It's a bit choppy and they slow down. So it's not quite a stuttering, but it's how you can,
Fluidity.
Yeah, exactly, fluidity, yeah. And then there are the cognitive symptoms. So this would be what would be under the umbrella term of dementia, I would say. So it's impoverishment of feeling, attention. So this cognitive slowing. So that's where you get the dementia aspects of something like Parkinson's. So that's actually next. And I want to just again talk about that a little bit. So what are some of the psychological changes that happen in Parkinson's? You get depression, anxiety, and again, this is one of these things. You think about Michael J. Fox, who can't get his toothpaste on his toothbrush, he can't shave. So you'd think that would make him anxious, that would make him depressed. And so this is one that's not absolutely, although I shouldn't say that. I think there's more and more evidence that it's the pathology that causes the depression. It's not the symptoms that cause the depression, if you see what I mean. So it's not that because people with Parkinson's can't do particular things, it's not that causes them to be depressed. It's that as the brain is losing its dopamine function, its dopamine tone, they become depressed, anxious. So developing dementia, and again, that's the memory or concentration similar to what's seen in Alzheimer's disease. And some people have actually said that Alzheimer's disease and Parkinson's disease have a lot of commonalities in terms of the dementia aspects that they see, although the underlying brain pathology is very different, except in some cases, of course. And the symptomology in Parkinson's is typically you have that added motor component, whereas that doesn't always happen in Alzheimer's disease. So causes of Parkinson's disease, or as it says here, Parkinsonism, because again, so Parkinson's and Alzheimer's disease really can't be completely verified until you actually take the brain out and look at it. So you can't say that, so that's why I say with Muhammad Ali, it's not clear whether he has the dopamine degeneration, the dopamine cell body loss, that would be, you know, classic to Parkinson's disease. Because he's been hit on the head so many times, it could be some other issue that's going on. So he has a Parkinson-like symptom. But, I mean, that's probably something that we don't have to get too much into, but in Parkinson's anyway, again, it's those dopamine-producing cell bodies that are lost in that little midbrain area. So just down here, it's just a, you know, a tiny little dot in the grand scope of the brain, but it's very important for sending dopamine throughout and organizing movements, organizing thoughts, things like that. So there's a lot of different causes of Parkinson's disease. There's obviously, I mean, people always say there's genetic components, there's inflammatory components, which I'll talk a little bit about, in fact, as we go along, but it gets really complicated. Encephalitis, so, you know, any infections in the brain. Drugs, this one I'll talk about a little bit because I think that's kind of interesting in terms of current things that are happening in our world, as well as these environmental agents. Pesticides such as rotenone and paraquat, which somebody here at Carleton actually studies in terms of how those relate to damage to those dopamine-producing neurons. So I just want to mention quick about paraquat because it's one of these things that, you know, I guess any pesticides that are in use or any chemicals that are in use can potentially lead to some damage if people are exposed to them chronically. And paraquat seems to be one of those. So it is used to control all these different types of crops. It can deliver safe, effective weed control, generating social and economic benefits while protecting the land for future generations. But it also seems to be highly associated with the development of Parkinson's disease. So this paraquat in animal models, if you give it to an animal, it can destroy those cell bodies in the substantia nigra. So it can damage the dopamine-producing neurons here. And just even at smaller doses than, let's say, some farmers or, you know, anybody that would be exposed to this pesticide would be exposed to. So it's a cause for concern, of course, because you don't want to be putting people in these fields and then, you know, flying over and spraying them with paraquat, and then, you know, 2 years later they're developing Parkinson's disease. So it's, you know, it's just one of these things that we need to consider as causal factors in really any degenerative disorder, because we just don't know what some of these environmental events are having, what the effect is on the brain. Yep.
Does paraquat get stayed on the vegetables and fruit that are sold, or is it removed?
Right, so then that's another big question, is whether that paraquat stays on those vegetables and then we're consuming it. So I don't know that offhand, but I presume there must be some traces of it. So I'll just jump around. So the other one that I wanted to touch on is this Mptp. So this was a drug, and I'll just put it up here because I think it's easier to just talk about it. So this Mptp is a related compound to this MPP, which again, it doesn't really matter, but you can see that there's only one switch in the letter. So what this MPP is a synthetic opioid, so like morphine or Demerol. So oxycodone, oxycontin are very similar to this MPP. And so again, what I wanted to just at least describe a little bit is that these street chemists, these drug addicts, were trying to convert some opioid into this MPP, but instead made this Mptp. So drug addicts are not necessarily chemists. They don't have PhDs in chemistry. They probably don't have any really knowledge of chemistry. They're just trying to see how they can convert a drug that's used for prescription purposes into a drug that can be used illicitly. And so what they did is as they're trying to convert this compound into this drug, what they did is they manufactured this Mptp, and when they took it the next morning, they woke up and they had Parkinson's disease. It was that fast. So it's one of these things that, you know, again, in what's happening currently is a lot of people get addicted to these OxyContinins, a lot of these opioid type drugs they start off taking them for pain relief, let's say, but then they become addicted to them. And then once drug addicts get their hands on them, they convert them into drugs that are much more powerful and much more highly addictive. So now what they've been doing is, making, so drug companies are making OxyContin tablets or oxycodone pills or whatever, so that drug addicts cannot convert them so easily into these, highly synthetic opioids that can be, used illicitly. But these drug addicts are still finding ways to actually convert those non-convertible drugs into something that's much more street-worthy, I guess, or much more valued on the street. But so again, the problem is they don't have really degrees in chemistry, and oftentimes they make accidents. They make this type of drug, and they destroy their dopamine-producing neurons, and they come up with Parkinson's. So this is another animal model that people have used, is to administer this Mptp to a rat brain. And just if we look at this middle one, what you can see is that in a normal rat brain, so in that they have the same midbrain dopamine cells that we do. So just down here, it's a cross section. You can probably from even